How are you? I'm Miranda. I'll be taking care of you today. It looks like that you got this trach last night, and we need to just do some care and kind of give you some education if that's okay. You feel up to it? All right, can you tell me your name and date of birth first? All right, House Smith. All right, Mr. Smith. The other thing that I wanted to ask you is I have some students here with me today, and I was going to see if it was okay with you if while I'm educating you, I also kind of educate them about how to care for this. Thank you, that's perfect. All right, well, let's go ahead and get started. I'm gonna put on some gloves. And I first just kind of wanted to talk through a little bit about exactly what that trach is, just so that when you're taking care of it at home, you'll kind of be a little more familiar with exactly what's going on. So the tracheostomy tube is what they put in because you were having trouble with your airway. So they put that in, and that's basically what is allowing you to be able to breathe. So right now you're not going to be able to do much talking. So we've kind of developed our way of communicating, and we'll stick to that throughout this education. All right, so the first thing is I have one of the tracheostomy tubes that they inserted in you last night. I have one here that I want to go through and kind of show you and get you familiar with it. For the students, when you have a patient who has a trach in the hospital, you should make sure that at bedside you have one of the tracheostomy tubes that hasn't been opened, just at bedside. That way, if there would be an emergency situation and the trach would come out, then you would have a sterile one that could be reinserted right at bedside. So we do have ours over here by the monitor at bedside, and this is the one I'm going to open and kind of walk through and show you. All right, so when we open it, the first thing to kind of make note of is Shiley is a brand, and that's the brand of tracheostomy tubes that we have here. But they do have sizes. This one is an 8, and that's what Mr. Smith has here. So I'm gonna open this up, and it's kind of in its own little packaging that's sealed, and open that up. And there are a few things in this that we're gonna look at. So we're gonna pull out the tube first, and this tracheostomy tube has what's known as an obturator. So the obturator is a solid piece of basically plastic that is inside of that tracheostomy tube. And whenever they are initially inserting that tube, that is in there to prevent any kind of tissue or secretions or anything from gathering in that opening as they insert it, okay? Once it's inserted, the obturator gets removed. And then this is hollow again, whereas the obturator makes it solid, okay? So that has to come out to restore the airway. The other piece to this particular one is what we refer to as an inner cannula. So an inner cannula is just an extra piece that goes inside of there. It's also hollow, so it allows us to maintain the airway. So not solid, it's hollow, and allows to maintain the airway. When your patient has a new trach, or if your patient has a lot of secretions, this inner cannula is just an extra safety feature basically. So if my patient starts having lots of secretions, those secretions dry before I realize it, and I go in and they're having trouble breathing, I can just pop out that inner cannula. All the secretions will be dried on this, and that restores the patient's airway very quickly, okay? Now, whenever we're talking about size, if you don't have the box, right, because most likely when your patients come in, if they've had this before, you're not gonna know the size, but the size is actually on what we refer to as the faceplate. The size is here. So this one is an 8, and it's right here on Mr. Smith, tells us that it's an 8. Now, a few other parts to this tracheostomy tube. So the inner cannula, and then we have the balloon port as well as the balloon or the cuff. So with this part is on the inside and this part is on the outside, okay? So this is how we inflate and deflate the cuff or the balloon that's inside the patient, applying pressure to the trachea in order to prevent this from moving. So when this is originally inserted, they're gonna inflate the balloon, and that's gonna inflate it, and it's gonna apply pressure to the trach to keep this in place, okay? And then this remains on the outside. Once this is inserted, we still need to keep an eye on how much air is in this balloon. And we do so by checking cuff pressures. So this is referred to as a cuffed trach, and it just means it has a balloon. When your patients initially get their trach, they're gonna have a cuffed one. Now, once they've had their trach for years and years, or they had it their entire life, they will transition oftentimes to one that's called cuffless or doesn't have this balloon that needs inflated, okay? So in order to check cuff pressures, we use what's referred to as a little manometer or a cufflator. And this little manometer has readings, so green good, red bad. It has the ability to remove air from the cuff or a little pump to add air. And this little port here is what we stick the external balloon to. So we're gonna pop that in there, and then it's gonna read around 10. So 10 isn't quite to the green, so I would need to inflate some more. So just very gently, I'm pumping this little balloon and I get it to the green. So it's around 40-ish, so that's good. So if I overinflate it and it's in the red, I can push this little button and that removes air. In most hospital facilities, respiratory therapists, they are the ones responsible for checking cuff pressures. However, you never know where you work at if it will be your responsibility. So just so that you're educated and understand what this is for. What we don't want is we don't want too much pressure on this balloon, because it is putting pressure on the trachea. And just like a patient who lays on their butt too long, they get too much pressure and they get a sore. If there's too much air in this balloon, it puts pressure on the trachea and it can cause a sore inside, okay? And we don't want that. All right, so I'm gonna remove the air from this one. And we're gonna put this to the side. The other thing that we need to kind of look at is when the patient has a trach, they may have an intercannula that is reusable or one that is disposable. So patients who have a disposable intercannula, it's gonna say so on it. So this one you can see it says, do not clean or reuse. That means it's disposable. So if I'm doing trach care, then if I'm with trach care, we're doing a couple of things. So we're replacing or cleaning the intercannula to keep secretions out of it, as well as cleaning around the stoma. So when the trach is inserted, it is inserted into a surgical opening called the ostomy, right? And so we're cleaning around that stoma in order to keep it clean and dry and allow it to heal. So that opening is what the tracheostomy tube is actually inserted into. And so with tracheostomy care, we're cleaning or replacing the intercannula as well as cleaning around that stoma, okay? Now, if the patient has a disposable intercannula, so it says do not clean or reuse, then what you would need to do is you would need to go to your supply room, making note of the size of the patient's trach. And you would need to find a intercannula. They're gonna be in a little package on its own, and you're gonna find the size that you need. So we need an 8, so we got an 8. This is a Shiley, which is a brand of trach, and my intercannula is a Shiley, so that tells me they match. And then I would just make sure that I have this, and then I would take this out and dispose of it and replace it with this one. If your patient has a reusable intercannula, it is important to make sure that it's cleaned properly and that it is not thrown away, okay? And we're gonna go through the process of cleaning and reinserting that intercannula as well as doing care around that stoma. So the first thing I'm gonna do is I'm gonna go ahead and put just a little drape over him. That way if there are some secretions, I don't get it all over him, okay? I'm gonna also make sure that I have my ambu bag and my suctioning hooked up just in case he would get into trouble and I would need to stop and oxygenate or suction him. So I have those right there at bedside. I am gonna go ahead and put a paw socks on him as well, just because I'm going to be messing around with that airway. I wanna watch him extra close. He is on the monitor over there, but just for my own well-being, since the monitor's that way and I'm kind of in a sterile procedure, I'm gonna stick the portable one on him just so I can see better. The other things I need is my trach kit. So here we do have a trach kit that has everything we need to clean the stoma as well as the inner cannula. And then I'm gonna need a couple pair of sterile gloves. I always grab 2 just because if something happens and I contaminate my gloves, I can easily just put a new pair on. And then I'm gonna need some either 0.9% sodium chloride or sterile water in order to do this procedure. Now, with the solution, you need to make sure that it has been date and timed if it's opened. So it's only good for 24 hours. If you open it, you need to date and time it. And then just as a reminder, when you do have something that has been opened previously, a solution, you do need to lip it. And remember, lipping is just the process of getting rid of some of that solution and trying to clean around where any solution could have dried and caused issues there. So my solution is new, so I did date and time it before entering the room, and I'm gonna set that there and use it. So Mr. Smith, we talked about what I'm gonna do. So what I'm gonna do is I'm gonna set this sterile field up with some supplies to be able to clean around your stoma and clean this inner cannula part that's in your trach, okay? I've got you all set up. Are you comfortable? Okay, so I'm gonna set my field up and we're gonna get started. Okay, so the first thing I'm gonna do is I'm gonna open my kit, and there's a little arrow here, so I'm just gonna open it away from me. And I got a trash can down here below me that I'm throwing everything in. So this is kind of what it looks like at first. The first thing I need is my drape. These gloves I'm gonna pop out without touching anything. These are some sterile gloves. I like to bring my own. The next thing I need is my drape. So the drape is in there to where I can grab like one of the edges. Remember, you have a 1-inch border that is not sterile on your sterile drape. So I'm just grabbing this on the edge here. So I'm in that 1-inch border. So I'm just gonna pop it open. Again, I'm just touching in that 1-inch border. I wanna make sure the shiny side is towards me. So right now, the shiny side is towards you. So I'm just gonna kind of turn it to where the shiny side is towards me. And I want the shiny side towards me because it's gonna go down, right? And so that allows me to put it down without reaching over. So it goes away from me and then towards me. And I can, in my 1-inch border, kind of get that straightened out. The next thing I'm gonna do is I'm gonna take and dump all my supplies onto the middle of my field. Remember, you do not want the supplies to be in your 1-inch border because then they're gonna be contaminated. And I don't wanna like reach my entire arm over the field. So I'm gonna just reach very gently over, and this can go right into the middle without me reaching over. And I'm not gonna touch it, I'm just dropping it very easily. I don't wanna touch the inside of my tray. My tray is where my solution's gonna go that I'm gonna use to clean. Now, this tray is not very deep, but it has 3 compartments. I'm gonna put saline in each of these compartments. I'm gonna use the larger compartment to put my inner cannula in, and that's where I'm gonna scrub it. The next larger compartment, I'm gonna use to rinse my inner cannula, and then the smaller compartment is what I'm gonna use to clean around the stoma. So when I sit this down, I'm gonna sit up with the big part facing me. And then I'm gonna grab my solution. I'm gonna put my palm to label so that I protect that label, so I always know what it is and the date. And then take my lid off, making sure not to touch the inside of the cap and contaminate it. And then I don't need to lip it because it's brand new, I opened it. I'm gonna go ahead and pour my solution in, making sure not to cross over my field. So if you're shorter or nervous, there are a few things that you can do. If you feel most comfortable, you can come around to the other side and pour your solution this way. Okay. And then replace your lid. And then my solution just goes right there where that I know where it's at, and it's on the table because I'm gonna need it for later. Okay. At this point, I'm going to grab my sterile gloves. And I have a big pocket, so I'm gonna stick my gloves in there. If I needed to, I could sit in here beside Mr. Smith. I don't think he would mind at all, would you? No. Okay. And then I'm gonna move my tray down, or my drape down. And this is where I'm gonna put my sterile gloves on at. Now, before I put my sterile gloves on, I always take a chance to look around. So there are a few things that I need to make sure that everyone always forgets to do before they put their sterile gloves on. And that is taking the inner cannula out and removing that dressing. So with my clean gloves on, I'm taking the inner cannula out. So I'm gonna put one hand on the faceplate, and then I'm gonna grasp those edges in order to squeeze that and pull it out. And then I'm not touching the part that was inside, I'm just touching the external part. And then I'm just gonna very gently drop it in that large tray without touching anything. And then I'm gonna remove the dressing. When I've removed the dressing, I wanna look for color, consistency of drainage, and make note of that. Now, this dressing is referred to as a fenestrated dressing or a drain sponge. The difference in it is it has this pre-cut slit. It is important that you do not cut 4x4s because it's not made the same way, and it can cause things to fray, and the patient can actually inhale those and aspirate. If you do not have something that's pre-cut, you can use 4x4s, but you should just fold them and place them under the faceplate of the drink, okay? So I'm gonna make note of this, color, consistency, drainage, and I'm gonna just throw that away in my gloves. Okay, everything looks good. Mr. Smith's doing well. The other thing that I just wanted to point out is that at this point, I do not need to do hand hygiene. I did hand hygiene when I come in and put on my gloves initially. I am not going to leave my sterile field to do hand hygiene prior to putting on my sterile gloves, okay? So, I take a look, make sure I've done everything. I'm gonna go ahead and put on my sterile gloves at this point. And when you are putting on your sterile gloves, take your time and open all your flaps so that you don't contaminate them. I'm gonna tint your gloves down. Now, you want to start with your dominant hand. So mainly I'm right-handed, so I'm gonna start by putting that glove on first. When I do that, I want to make sure that I'm making note of a couple of things. With sterile gloves, this package is a sterile field. So just like we refer to this is the same thing. It has a 1-inch border that is considered non-sterile, meaning that when you're moving these gloves around, you don't want to slide them into your 1-inch border. You also want to make sure that as you're putting these on, the paper does not cross over your sterile field here and contaminate it. So we're thinking about all these things. When you grab your first glove, make sure you're grabbing in the middle of that cuff. Do not touch the field, okay? So I'm gonna grab in the middle of the cuff and pick it up. Now what I usually do is this cuff, this part, the cuff, it's not sterile now. So open it up, don't be afraid. And then stick your hand in. Take your time, right? You're not in a rush. You're just trying to do it right. And you may get into a situation where it doesn't work out. That's okay, right? So this is why you bring an extra glove, right? So if you get in this situation, it's fine. Just start over, right? So that's why you always have a second pair of gloves. So again, we're gonna go through, we're gonna take our time opening all the flaps on our gloves, right? So. We're gonna do our dominant hand first. And remember, I'm gonna grab the cuff in the middle of that cuff, and you guys know how sometimes our sterile gloves are. So, and that's fine. I can fix that later. I'm gonna step back here and I'm gonna open the cuff up so I can get my hand in. So, there's my thumb. My glove goes on and I'm just, again, touching the inside of that cuff. Now, with this second glove, regardless, this hand is sterile and I can touch this glove and move it wherever I need to. So if I wanted to put it back exactly like it was, I could, right? What I generally do is I take my non-sterile hand and I kind of hold in my 1-inch border, my paper, so that when I'm moving this around, it doesn't slide over into my field. I usually pick the glove up and turn it long way so I have more room to work, right? And then the goal is to get this hand inside of the cuff. So I'm just putting that inside of there. And while I'm doing this, I'm gonna throw that out of my way. And basically I'm trying to get this cuff down on my hand as far as possible. And then I'm gonna spread my fingers. Remember, once my non-sterile hand is going into this glove, my thumb cannot be touching the outside of that cuff because this outside of the cuff becomes non-sterile. So that's why your thumb needs to be up. That's why you can't hold it like this when you're going in, okay? So thumbs are up and I'm just sliding that in. Remember, this glove, if I mess up, it's not as big of a deal, right? Because I can fix it whenever I get done, okay? So we have our gloves on. We messed up the first pair, but we're fine. That did not hurt us. It did not do anything. So now I can go ahead and I can kind of set up my field. That's what I like to do first. So I'm gonna separate my 4x4s to dry my inner cannula and my fenestrated dressing. My fenestrated dressing is the last thing that I'll use. And when I'm laying everything out, I wanna make sure I don't put it in that 1-inch border. This is a trach tie. This is not a safe one to use, so we're gonna throw it in our trash can down there. We have a little scrub brush. We have pipe cleaners to clean the inside of our tracheostomy tube. And then we have all of our cotton swabs that we clean around the stoma with, okay? When you are setting up your field, make sure all of your tips are facing away from you, and there's a reason for this we'll talk about later. So I'm just gonna lay them there, okay? All right, so the first thing I'm gonna do is I'm gonna take my little scrub brush and I'm going to clean my inner cannula. And I can see his pulse ox still. I'm kind of moving the table with my foot. I do that sometimes. So I'm gonna take, and the best thing to do really is to leave the inner cannula in here and kind of brace it and just scrub it that way. What you don't wanna do is you don't wanna step back with the inner cannula, because what's gonna happen is it has water and secretions on it. You're gonna get those all over your shoes and your clothes. So you wanna leave it in here to where you can control it. If I'm doing this with a real patient, if I'm going to have to scrub this, then I need a face shield and things on, because this can easily splash in your face. Okay, so I'm just scrubbing. And then I usually just leave that sitting in there, and then I'm gonna rinse this out in my other little container. And because I'm done with this, that's why I'm able to reach over, right? So you see me reaching over the bigger basin. I've already scrubbed it. I'm not gonna go back to that, okay? And then I kind of rub my fingers together. I'm gonna grab my 4x4s, and as I'm drying this, I am kind of drying my gloves as well. Okay, and then I'm gonna grab my pipe cleaners, and I'm gonna stick those inside because I am drying the inside of the inner cannula as well. Okay, and then those in my trash. And then the next thing I need to do is replace this. This is the most important part because this part is sterile. So I don't want this to touch anything because that bacteria could go down the patient's trach. It could end up giving them pneumonia, okay? So when I put this in, that's my most important thing, is to make sure that I keep that sterile. And I'm gonna push it in and it's gonna snap, okay? Now, the next thing I need to do is I need to clean around the stoma. So underneath this faceplate, I need to clean top to bottom on both sides around that stoma to get any dried secretions or things like that just away from it, any bacteria that's collected. At this point, it's not important if my hands remain sterile. So when you put the inner cannula in, if you're nervous and you're shaking and you touch the patient in order to get that in, it is okay. That's why our Q-tips are all facing away from us, because we can touch the handles or the bottoms with our non-sterile gloves and just the tops remain sterile. So it's completely acceptable for this procedure. All right, so in my last little container there, I'm gonna get saline and kind of hold this, go top to bottom on that stoma, throw that away, get a new one. I'm gonna do the same thing, top to bottom, and dry it. And then the other side, same thing, saline, top to bottom, and then dry one, top to bottom. And then if needed, the faceplate, I could do the same thing with it. Clean it top to bottom on both sides with a saline and with a dry Q-tip. Okay, but the faceplate looks good, so we won't worry about that. I'm just throwing all those in my trash can. All right, so the next thing we're gonna do is we're gonna go ahead and change his tie. So I like to change the tie before I put his fenestrated dressing on, because there is Velcro and the Velcro can get attached to that and kind of make it ratty looking. Really important that the old tie stays completely on until the new tie is completely on, right? Because what we don't want is we don't want this patient coughing and that tracheostomy tube coming out and them losing their airway and potentially having an airway emergency, okay? So I'm gonna go ahead and put this on. I'm gonna put it behind his neck because he can help me. And then I like to always go ahead and put the new one on either both sides at the top or both sides at the bottom. So it always works for me to do the top. So I usually fold that over, gives it a little stiffer, and I'm gonna stick it through there. Sorry, Mr. Smith. And then I'm gonna go ahead and secure one side, and then I'm gonna do the other. Same thing, I've got it on the top over here. Sometimes this is the hardest part. Okay, and then we're gonna go ahead and secure that. And now that that's secured, I'm gonna go ahead and take the bottom one off. That's the old one. I'm gonna pull that through, and I just like to hook that Velcro to something. And sorry, Mr. Smith. And pull that off. Once I get that old one off, I'm gonna go ahead and check that the new one is tight enough. So I want it to be 2 finger breaths. So I don't want it to be too loose because it could come out, but I don't want it to be too tight because his carotids are there. Okay, so 2 fingers, good. Feel okay? Perfect. All right, the next thing we're gonna do is put the fenestrated dressing on. The fenestrated dressing is not sterile, but you do wanna keep it as clean as possible. You wouldn't wanna drop it and then use it on the patient, of course, right? So the whole point is that this is gonna go up and around the stoma to collect any drainage. This may need changed more times than you are doing tracheostomy care, okay? All right, so I'm just gonna lift the edges up and kind of get that underneath the faceplate and the tie as good as possible. Again, because we want it to collect that drainage so that it's not running down Mr. Smith. And I've been paying attention to his pulse ox. It's looked good throughout the procedure. When we do go back to the nurse's station and we document about this procedure, there are a few things we do want to document. We want to, of course, document how the patient tolerated the procedure. So Mr. Smith seemed to tolerate it well. His pulse ox remained in the high 90s, so between 98 and 100%. His heart rate remained in the 90s, so around 90 to 91. I used sterile technique to clean around the stoma, as well as to clean and reinsert the inner cannula. The inner cannula is a size 8. I did replace the fenestrated dressing and the trach tie, as well as note the drainage. So the old fenestrated dressing had scant amount of clear drainage, and then I just want to make sure that he's comfortable, he's got everything he needs. I can kind of remove all the stuff that I have put beside him here for precautions. Of course, want to leave my Anbu bag where I can get it, because this is going to be something we're going to keep doing. Okay, put his rail back up. All right, Mr. Smith, do you need anything? You feel okay? All right, so I'll get this cleaned up, and you've got your call light, and if you need anything, you let me know. All right.